Hi, everyone. Welcome to Quality, where we're exploring quality in emergency care. This is Arjun Venkatesh, your host and lead of the Emergency Quality Network. Today, we're joined by a really special guest, Stephen Rollnick, who is the Honorary Distinguished Professor from the School of Medicine in Cardiff, Wales, and really considered by many to be a founder of motivational interviewing. We're also joined by Dr. Kate Hawk from Yale, who leads the Substance Use Disorder Initiative in the eQual network. And today I'm going to sort of open it up by what I'm guessing many people may be thinking after that introduction, which is, what are we doing on a United States emergency physician podcast talking to a distinguished professor from Wales about motivational interviewing? Stephen, do you have any idea what's going on this side of the pond?
I've been over many times actually, and great admirer of the work of Ed Bernstein in Boston City Hospital Emergency Medicine. So he was a good friend, but I think you're right. It's worse than that, Arjun. I'm a clinical psychologist. Not only that, I come from Cape Town, South Africa, and it all started for me in Sydney, Australia. So, I don't blame you for wondering how familiar I am with your world, but I would say reasonably well.
That's great. I think, particularly the work, one of the things we have found working in this space has been that while there are certainly numerous differences in healthcare delivery systems and how hospitals are organized and how we pay for healthcare, particularly when we're talking about substance use disorders, there is a lot that is common across different nations. There's a lot that is common in terms of challenges and sort of what have you seen? You've worked across so many different countries in terms of these themes that emerge where everybody's sort of dealing with the same problems in many ways.
Oh, huge commonalities, honestly. And I've tripped across African countries and Australia and many countries. I think it's quite apparently simple human problem, which is that you're looking after the medicine and you can see here in front of you someone who's struggling with a habit issue to do with alcohol or opioids or whatever it is, and you're busy. And what can you do to reach out to them and touch them in a way that helps them consider the possibility of change or referral on? So I've not come across a setting in a country where practitioners don't encounter this. So I'm hoping we can cross borders and cultures in this discussion.
Wonderful. We're so grateful for you to be here with us today. Before we get into how we can think about implementing these maybe in the emergency department, I'd love to hear a little bit about where the concept of motivational interviewing came from and why you think it works.
Great question, Kate. It came from the addictions treatment field. And a fellow from Albuquerque, New Mexico, a psychologist called William R. Miller, and I have worked together through 4 editions of our basic textbook on this. And it came from that setting based on our experience of having difficult conversations with our patients, okay? And motivational interviewing, or MI, is a style, if you like, for talking to people about change with associated skills and strategies. And you're asking me to kind of summarize 40 years of my life in a few words, but let me just try. This is a shift in style from legitimately doing things to or on people as part of your everyday work to being with them. It's quite a shift. And then instead of telling or persuading them to change, you come alongside and guide them to say and why and how this change might come about, supported by your best advice, but not dominated by it. So if you take that description, I think I got it reasonably clear, yeah? It is that simple, like soccer. It's simple, you kick a ball, right? But it takes skill to do it well. And it's something you can work on and integrate into your work over time. Now, I think you also asked, why does it work? That's a really big question, Kate. I think people like to make decisions for themselves, supported by your best advice. But across cultures, that is the impression I get, that they like to be heard and they like to make decisions for themselves. And MI helps them to do this. Now, it's taken a variety of forms over the decades, depending on the setting and the practitioners and the professional group. There are now over 2,300 randomized trials. So please don't ask me to summarize this, okay? But there are many trials and reviews in emergency medicine. Okay. My understanding is that there's a reasonably strong empirical basis to its use in emergency medicine. And there's a story I could tell you about my experience in emergency medicine, but I don't need to do that now, okay?
But I think it raises a good question I think we often get, which is a lot, these trials for motivational interviewing, particularly even the ones in emergency medicine, they've been conducted over the last couple decades.
Yeah.
And on the ground, we have witnessed a real change in the clinical delivery of emergency care. And these are global problems right now. We are sort of at this unprecedented tipping point of crowding in emergency departments and hospitals. And I think often when people hear the word motivational interviewing, in their head, they think of this, there's an emergency physician and a patient in a quiet room, and you have sort of a little bit of peace and the ability to engage with somebody. The reality is half of our patients get care in a hallway space. We have shorter periods of time than before. And I guess the question I would sort of ask that people would come back to me and ask is, can you be successful with motivational interviewing under these capacity constraints that we have today? What are the parts of it that can work if you don't have the perfect environment? What can you do?
It's a great question. And I've explored this in many forms. And I would say there in that hospital corridor, there is a challenge. It depends how many minutes you've got, but there is a challenge to connect rapidly with a human being who's in front of you, not just a patient. That's part of the shift. A human being who likes to be heard and have choice. So if that's your starting point and your attitude, you can speak to them about why and how they might change in anything from 30 seconds to 2 or 3 minutes. And I could give you some guidelines or an example of each. But I imagine, which I can very happy to do, Arjun, we can go on to that. But I imagine you will still have viewers wondering, but why, even if you could do this, why do it? And I thought I'd tell you a quick story, which is, I was following the work of a Swedish physician called Hans Christensen 40 years ago exactly, who found that just giving folk brief advice about their alcohol use was effective. That spurned, decades of research on what they call brief intervention. Why do anything else than just simply tell someone what to do? One day, a conversation with a nurse hit me between the eyes. She said that she was finding it increasingly demoralizing giving advice to patients in this way, particularly with alcohol use disorder, because they too often argued back against her. And I just started using motivational interviewing in my clinical practice, and I wondered whether it could be used in a hospital setting. So I set about doing my doctoral research on this, and then I wrote a few books on the use of MI in different healthcare settings. But really, in summary, looking back, MI can be used in shorter and longer conversations about any change for a patient, whether this is substance use, medication adherence, or whatever. So I just wanted to clarify that there's a clear rationale for using it, which is that giving people just a little bit of space to be heard and to ponder aloud with you seems like it's more effective than simply dishing out advice. And the point I was making about the nurse is that it's beneficial to the well-being of the practitioner because you're not hitting your head against a brick wall. I wonder, am I rambling there?
No,
Is this making sense?
no, you hit two really important things, nails on the head. Just there. I think one of them really is, it seems like you're at the forefront of patient-centered, patient-centered medicine, right? This is the idea of really respecting patient autonomy and really elevating that in, care decisions and care choices, which has not always been predominant, certainly in US medicine. And the other thing that you hit on, which hadn't even occurred to me that we were going to talk about today, but it's one of my favorite things to think about in this space, is how protective this work can be for clinicians when it's rewarding for everybody. And I think you've highlighted a particular style of interacting with patients that is really rewarding for both the patient and the clinician. So thank you for that. It's been really wonderful to see where these conversations can go with patients. I wanted to circle back around to another sort of aspect of this, which again, you also highlighted, is the idea around this is really, around finding and enhancing the patient's motivation, or the human's motivation, as you pointed out. As clinicians, we have really good ideas about what people should do and how they should do it. And so, for example, when you're talking about someone that has untreated opioid use disorder, it is hard to keep our preferences at bay while we're really allowing the patient to explore sort of their ambivalences and where they are around accepting treatment. I wonder if you could talk a little bit more about that tension and how we might best think about that, particularly when we don't have years to work with the patient, right? We have, what might be a brief encounter.
So what is it that you're wondering here? Have I got you? You're wondering how does a practitioner connect with the patient in these conditions? Or have I got you slightly wrong?
Well, so I think the connection part is easy. I think the part that is a little bit more challenging is respecting the individual's choice to say, you know what, I'm not interested in treatment right now, but I am interested in talking about harm reduction, and how you sort of navigate that conversation around a motivation that might be different from what the clinician had hoped.
I think, look, I've been at the receiving end. I had a cardiac issue and sat in a corridor and noticed the behavior of the practitioners around me. I think it is possible to briefly connect. You need to be genuine and authentic as one human being to another, and your attitude, you want that to be one of kindness and care and concern. I mean, this is completely foundational for good care. Forget about whether it's patient-centered or not. But look, you then want to initiate a conversation, because this is not just a sort of a never-ending conversation where you're listening and listening and listening. So what we've done in motivational interviewing is provide some structures and strategies and skills for doing this. And I'm more than happy to describe some of these to you, or give you an example, or consider the difference between 3 or 4 minutes and 30 seconds. Where would you like to take the conversation?
The one I can think about is it's sort of building off of where you're there. Is we want to create this, I don't know, this concept of self-efficacy, or really a world where the patient, the human in front of you, really feels not just sort of engaged, but in charge of their care. And I often think about, there's these sort of large forces that go against that. One is the nature of care delivery is one where we really take away a lot of control from patients. They're often told to stay in a stretcher or a bed. They have to wear a gown versus their own clothes. Sometimes they'll have cardiac monitors on their chest. And so it's literally an environment where sort of you feel very low control. And you put on top of that, we know a lot of stigma from healthcare providers. That stigma can often manifest, particularly in a busy emergency department, manifest itself as, I know treatment is the right answer for this opioid use disorder. Sort of, why won't the patient do it? And one of the things I'm trying to really figure out and think about is, how can we flip that momentum headed in the wrong direction in that emergency department encounter? How do you support that healthcare practitioner to sort of, pause, go against their stigma? How do you sort of help the patient see that there is control when it feels like there's not?
Yeah, and I remember vividly, I believe it was in the middle 90s, of being in Boston City Hospital with Ed Bernstein and training a group of his folk in the emergency medicine department. Look, there's no one way of doing it. You know, I'm talking about generalities. You need to be a human being yourself, reaching out to another human being in a very brief period of time. And I personally find the framework for giving information and advice that we've developed in MI to be the most useful in these super brief conversations. Okay, but there are other strategies that can be used. But to bring that to life, if I'm standing in front of somebody on a trolley in a corridor, I need to reach out, connect, introduce myself, ask permission to discuss their health and lifestyle briefly, be honest about why you're there, and ask them very briefly about their everyday life and their use of alcohol, opioids, or whatever. Okay, and you might hit some resistance, so to speak. You might, or not. Okay, but having listened for a while, I would then shift to this offer phase of ask, offer, ask. I'd shift to the offer phase and literally not dump down information, but offer up advice. And I would offer up my best advice. I would provide options if I can. Here are some of your choices. And I'd use modest language, noting all the time that it is their choice. Then I would return to the ask and ask them what they might do and what help they might take up. Okay. So that can be done in a couple of minutes quite easily. But then there are also other strategies which I'm more than happy to talk to you about. But the essence is to connect with somebody at the same level as them, with concern and compassion in your heart, and structure a conversation so that they get a bit of breathing space to consider why and how they might change. I think that's the essence of it. How does that sound?
And for those of you that weren't quite sure what motivational interviewing is, he just described it.
Yeah.
Anything else that you can think of that would be helpful resource-wise for clinicians who are interested in learning more around how to, I mean, clearly this is not something you can learn from listening to a 20-minute podcast. If there are, resources that people can go to help either improve their practice or learn more about it.
Sure. Look, there are books. Okay, there's books and papers, and you can type into Google keywords and get useful stuff. There's a website called motivationalinterviewing.org, which is run by trainers, an international group of trainers, and there's useful stuff there. There's a website that both Miller and I have, a company that Miller and I have particularly attached to, called PsychWire. Okay. And over the last 10 years, Miller and I have invested a lot of time in working with this high-end production company to produce online learning resources. Okay. And you'll find a module there on motivational interviewing in healthcare. Okay. What else? I think that's probably it, Kate. There are trainers around, which you can find on that motivationalinterviewing.org website. You can bring them in, but really it's a personal journey. Imagine trying to learn to play soccer or ski for the first time. You've got to put effort in and commit yourself to it, but it's not too complicated. My advice to myself, okay, and I offer it to you as well, is I've got a little thing in my head, which I call my 6 C's. So when I meet someone in a difficult situation, which I do in my everyday work life in a different setting, in a corridor, blah, 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 I let go 3 things and I hold on to 3 things. The 3 things I let go are complexity, clutter, and cleverness. Okay, because cleverness can be a trap. So I clear my mind, okay, and I hold on to being calm and compassionate. And guess what? I've forgotten the third one. I'm 71, I'm allowed to, okay? But I hold on, and curious, okay? Curious is a key word here. You don't have the answer, they do. But what you can as a professional do is raise key questions and offer your best advice in a way that champions their autonomy. That's it simply. And if I had 30 seconds with someone, shall I tell you what I would say? I tried to sort of write it down, okay? But if I've got a friend, Chris Dunn, who's, where is he? Seattle. I think he's probably retired now. He's been doing this on trauma wards for decades, okay? Just quick, whoop. And I reckon Chris, who knows more about this than me, would probably say I'm getting it pretty close, right? I'd be authentic, kind, but not pushy. And I'd say something like, I've noticed that your use of alcohol, opioids could be an issue or a problem, but your body's got a wonderful capacity to heal. And I wonder how you see your future panning out for you with alcohol or opioid use. How do you see things panning out for you with this? And I must apologize for not having more time today to discuss this, but my advice is to seek some help and to give it some serious thought. And we can refer you from help here today if that's something you'd like to do, but this is completely up to you. Okay, so that took me about 40 seconds.
No, that's good. Can we do one more question? We're going to put it earlier in the podcast, but here it is. Many of our listeners are often medical directors of emergency departments. And so this isn't just about us sort of helping individuals change their practice, but often many of these motivational interviewing interventions in EDs are done as an organization or done as a group, right? It only works if sort of you engage all the physicians, all the providers in doing something like this. What is your advice for those leaders, those medical directors who are trying to implement a program at the organizational level?
Be curious and connect with your clinicians, and in fact, use motivational interviewing, if you like, and offer this as a possibility to them with some choice. If you just impose it from top down, you'll find you'll have adherence issues for precisely the same reason that clinicians have found this in clinical encounters. And it's a real tricky one, this, for managers. I've seen it work, okay? I've been in, for example, the most recent was a whole respiratory medicine team in a big London teaching hospital, extremely busy public health setting. But once a week, that group of 30 to 40 people, all sorts of practitioners, would meet, have lunch, talk about cases, and learn motivational interviewing together. And it was dynamic and impressive to witness. But setting something like that up can only be done with the goodwill of a few champion practitioners in the group, and an invitation to the others to gather around and just discuss this as a potential, as a possibility. Now, what you might find is that only a third or a quarter of them want to take this up. Good practice grows and the others will become curious. That's what they found in the respiratory medicine thing. Started off with a relatively small group. It got bigger and bigger. And by the time I joined them, they were a dynamic, they were relaxed, they were a happy group, and the social cohesion between them was developing as a byproduct, if you like, of the special hour and a quarter, I think it was, they had each week. So there are a few thoughts on that one.
No, I think it's a great point. You know, one of the things we know is that we talk a lot about now in the emergency medicine world, how people are feeling moral injury. It's sort of this inability to act or take care of the patient before them, and then that drives increasing senses of burnout. But I think in the same way that we want our patients to have self-efficacy, we also want our teams and our providers to have that self-efficacy. And I think sort of as you describe it, we probably find that, as projects are successful, any kind of quality improvement intervention, and people feel like the care they're delivering is improving outcomes and helping patients, and they're sharing in that sort of success together, that it cuts against that, right? That's the sort of joy in practice we're trying to help them find.
Yeah, chatting among yourselves protects from burnout. Okay, just because of the human connection and support that happens in that kind of environment. I see it here with the elite sports coaches, which is where I'm working now. So they face similar threats to their well-being, but getting them together, chatting things through. But here we're talking about a focus on learning ways of using motivational interviewing in everyday practice. It gives it a focus, but it's not the only thing going on.
Well, thank you, Stephen. This was a wonderful conversation today. I really appreciated it. I think many of our listeners are probably feeling like me, which is I have even more questions now than I did at the beginning of the podcast, but that's the point. That's the goal. And I think that I'm at least walking away from this with a few things for sure. One is an appreciation for the fact that motivational interviewing can be successful even in our current challenging practice environment, that it doesn't have to be perfect off the bat, and that we can really build our teams and support our teams in this tool. And that there are some real sort of proven techniques, that this is a remarkably strong evidence-based intervention in the same way that we think of some of the drugs that we use to treat substance use disorders as being, the best class of evidence-based intervention that we have out there. The same is true for motivational interviewing. And I think that those are some important things I walk away from this from. So thank you for joining us. Hopefully we'll have you back again in the future. And I thank you all to our participating sites. This is the next in our series for our substance use disorder equal podcast, but not the last.